Hello, everyone in the audience and on Zoom. Welcome to the School of Dentistry seminar this month. And this month, we want to showcase our research by our Paediatric Dentistry group, and led by Dr. Sobia Zafar. Okay, we have three speakers today, and I hand over to Sobia.
Thank you, Locke. Let me know if I'm audible. Okay, good. I walk around, so I will keep the mic in my hand as well. Oh, yeah. Sorry, you're on Zoom. Okay, I will stay here. No worries. So what we're going to talk about today is what we are doing in pediatric dentistry. So mostly the advances as well as our research teams and our research group and the members. So this is just the overview of what we're going to do today. So the two members of our team, Dr. Yvonne Lai, who is final year of her PhD, and Dr. Thomas, he is going to talk about, he's the final year of his MPhil program, and he's going to talk about his presentation as well as the research. So just to give you a brief overview about my role, you all know I'm the discipline lead for pediatric dentistry. I've taken up this role in 2018, to 30th of July 2018 at UQ, to be exact. So I am involved in teaching as well as research, and in addition to that, I also have some roles in engagement as well as service, and I have full citizenship of UQ as well. So I have supervised DMD students, BDSC honors, quite a few of them, DClin Dent, I'm supervising them, and Phil as well as PhDs. So if you look at the school website, this is where you can find our research group. We come under clinical research units, and then under the discipline pediatric dentistry. And we're going to talk about basically some of the members and the current project, future directions, and our publications. So the research team that we use are around two main areas. Dental education, which also include digital dentistry as well, and then the oral and dental health of children, including those with special needs. So I am the group leader, and our other members are Dr. Sakhar Al-Qatani and Dr. Kartika Balaji, she is related with Metro North. And then we have got students, PhD students, Dr. Yvonne Lai. Then I have another student that I co-supervise. She's also in the final year with Mark Tennant at UWA. And Amjad right at the back as well, who just started with us. And so I have nearly 5 MPhil students, and Tom is finishing up, and quite a few coming up who have reached the confirmation milestone, and some of them are getting towards that. Honors, I have undertaken quite a few honors students as well, and most of these students have completed, and some of them are in the process of completing. So my research teams, as I said, that fall under two main areas. And this is how I divide my students as well and provide the supervision. So for the oral and dental health of children, we can remove the oral, and the dentistry, we have got the PhD, DCD, and other students there as well. And the digital dentistry, some of the DClin Dent, PhD, they are part of this one. And when I take the honor students there, the honor students also come under these two major umbrellas of pediatric dentistry. So let's talk about some of the themes that we have covered under dental education. The first thing to start with is what is taught at UQ and how we can improve it. So what we thought about is understanding the building blocks of pediatric dentistry, and moving on from pediatric dentistry, the other part is S&D, special need dentistry, and moving towards orthodontics as well does. So this is where we all interlinked with pediatric dentistry. As a pediatric dentist, you do work in all these disciplines and areas. There is nothing that you're not aware of. So everything extractions to whatever I say, dentures, we like, that's the extreme, but we do that. So the other thing is the local anesthesia. Local anesthesia, giving it to the child is always a very challenging practice for our students as well as some of the clinicians, especially in a child patient. So I have put a lot of effort into it and I've come up with some models that can provide the extra benefit to these students to work on that one. Then dental trauma. This is another area that when we work towards the dental curriculum in pediatric dentistry that require the attention. We came up with 2 new models that has been published in the dental traumatology, one last year and one just very recently. And the other one, the third one, is just came out in the Australian Dental Journal as well. So it's the parental knowledge as well and how we can improve it. Child abuse and child neglect is another area that we think about it. So we have done a local survey and then we have done a multi-center study. I was the lead author on that one, using 11 dental schools in 10 countries, which is also published in International Journal of Paediatric Dentistry, which is the highest impact factor journal for our pediatric dentistry. So these are some of the research areas and the highlights just for you to look where we are working and where we are. Now, the next research theme is the digital dentistry. I have worked with augmented reality, HoloHuman, which was purchased by the HABs from the school. And within the world, we are the first group who worked with the HoloHuman in dentistry and published the paper in Journal of Dental Education. This paper is just published, but so far it has been cited 27 times already. Then the virtual reality model that we are using is the LAVR model that has never been used in pediatric dentistry before. So this model, I have some of the slides to show you how it works. And then some of the 3D scanners that I work with, both for the prosthodontic as well as stainless steel crown preparation. I have some slides to show and go through that easily. So this is the HoloHuman. I already told you this has been quite a few citations since it has been published. Then this is the model that we created. It is the first pediatric LAVR simulation model. This model has gained a lot of attention worldwide. We've got the collaboration from University of California. We have got the collaboration call from the University of Canadian Universities, and we are also collaborating from 2 other universities, and we have already published 2 more papers, which is not the same thing, but a similar thing. So when we use all this AR, VR, or digital technology, what we find that the students feel more engaged, working towards or using this, and they feel like their learning experience has been enhanced, or they have been provided something in addition or adjunct to what they are used to of like within the simulation environment. So the other thing is the Simodon. We don't have any Simodon. Kasha, we are the only school in Australia without a Simodon, but that's fine. It's past. We have got stuff that's in the future, which the other schools don't have it. This is the study I completed with my job when I was in UWA. Yes, Sasha? Yes.
How many dental schools use Simodon?
That's the question. That's it. Not many.
I saw what happened with Simodon.
Exactly. That's it. But this is exactly I can come from. These Simodons, they do have a lot of technology that we can utilize. They have been underutilized. So while I was there, I was the first group who came up with the idea of providing the alternative module for the pediatric practicing. What is it? Pulpotomy and stainless steel crown. So, which was always there in those Simodon models. Nobody used it. We have worked on it and it works even better. And but I think we have moved forward. Yeah, you're right, Sasha. See, the other thing is the crown preparation. These crown preparation we use all the time. It provides the assessment, self-assessment for the students. Rather than waiting for the supervisor to come and give the feedback, they can go scan it and compare it with the master model. We have done it for the prosthodontic crown preparation. This is when we started, when we didn't have any of the crown preparation in our archives. And then we started the similar one for our stainless steel crown preparation. These are the stainless steel crown preparation for the pediatric one. Then another model that we have worked with is a 3D trauma model. Trauma is another thing that I always feel very interested in working. We created a 3D printed tooth. And if you look at this tooth here, the size of this tooth is smaller compared to the normal one. And it is done on purpose so that it is loose when we put them back in the alveolar socket, and how the students can put their splinting wires on that one that has been tested. It was quite popular, and some of the ideas that we get out of this paper, we put those ideas from the students and did another paper and collected the 2 years data that has been published in dental traumatology. It should be online very, very soon. It's not yet there, but it should be online. This is some of the collaboration that the other universities have asked me to put forward with them. This is one of the paper that we have done it recently, and there is another one that has come through collaboration. Now, the research streams regarding the oral health of the children, I will actually leave it for Yvonne and Tom to discuss a little bit more, but just as an overview, what we are doing as the oral health of children and the special needs that we talk about. Quite a few papers that we have published in this domain as well, and we have been collaborating with our S&D colleagues as well, because this is the area that we all actually overlap. And these are children, even if you are orthodontic, prosthodontic, whoever, not working?
Sounds a bit low. Just
all right.
I think I'll just check something.
I'm finished.
Okay.
Just last slide.
It's in the water. So, because of this microphone. Yeah, it comes from the webcam on the.
Yeah,
Is it better, guys?
I think it's going to be better.
I was on the last slide. Anyways,
Sorry.
that's all right. It's okay. So just to let you know, this is my final slide. And as I said, that we will talk about publication. I got my specialization in 2016 from University of Otago. And since after that, I got a job at the UWA. And when I was getting this degree, my supervisor, Professor Gregory Seymour, he said to me that now you're going to go in academics, you need to publish 10 papers a year. I looked at him in disbelief that how I'm going to do it. He said, you will do it. I know you will do it. And he sent me away with this. So it always stayed there that I need to do it. Then I met another colleague from UQ, Professor Camille Farah, who was our head of the school. And he said to me, he asked me the question, how many publications you're going to do it per year? I said 10. And he just laughed. And he said, how did you think about you're going to do 10 publications? 2 publications a year in the good journal is what I'm expecting from you. And I was like, okay, I have this big burden, I have to follow my supervisor and then my head of the school. And once you graduate, you always need to know it takes some time to get to the point where you have established your research group as well as your own areas. So in 2020, so I put this line on 10. Yes, I have exceeded that mark. 2021. Yes, I have. Professor Gregory Seymour, if you are listening to me, I have fulfilled what you said. That's it. I kept the promise. 2020, we have already reached, but we are right in June, 6 more months. Hopefully, we're going to cross that mark. Thank you, everyone. And if you would like to contact with any of our group member, please feel free to. Over to Yvonne. Yvonne or Tom? Tom. That's all right. Yes.
All right. So good morning and thank you all for attending my talk. For those of you who heard this 5 weeks ago, I do apologize in advance. So as introduced, my name is Tom, and the title of my talk today is The Effects of Decontamination Practices and Diet on Preformed Paediatric Crowns and their Biocompatibility in the Oral Cavity. And this presentation really forms the basis of my master's, which is in its final stages, and we should be submitting externally in a few weeks, which is nice. Now, preformed crowns are an essential part of the paediatric armamentarium, and we use them for a variety of conditions. Overwhelmingly, dental caries or early childhood caries is the most common reason, and this is the most common non-communicable disease in children. Now, the World Health Organization estimates that over 500 million children are affected, and in Australia, overwhelmingly Indigenous children are more at risk of this disease compared with their non-Indigenous counterparts. Oh, sure. I'll keep looking at the mic, be easier. In addition to caries, there are a number of developmental defects in which we use these devices for, such as molar and incisal hypermineralization, which affects approximately 14% of children worldwide. And in the images shown here, we can see an example of early childhood caries, and below that, an example of a hypomineralized molar. Now, there are different types of preformed crowns available on the market. We have the traditional preformed metal crowns, also known as stainless steel crowns, or the veneered version of these stainless steel crowns. We have the much newer zirconia crowns, polycarbonate crowns, which aren't used particularly much nowadays, and of course, the composite resin strip crowns. In the images shown here, we can see a pediatric oral dentition, and the take-home point here is that we can have a number of different materials in the oral cavity at any one time. So the green dots represent the positions of the preformed metal crown, and the orange dots are representing the pre-veneered version of this stainless steel crown in the anterior segment. In the images to the left, we can see a stainless steel crown, and to the right, the zirconia crowns. And again, to the right of this, we can see a schematic diagram of the periodontal tissues. And the take-home message from this slide is that these crowns are in direct contact or very close to a number of different cell populations in the pediatric oral cavity. Now, one of the themes or questions of this project was looking at issues with reprocessing and reusing these crowns after sterilization. So the vast majority of pediatric dentists reuse these crowns after they've been exposed to potentially infectious bodily fluids during the trying procedure, and the contaminated crowns are then re-sterilized. In the image to the right, you can see just how many different sizes are available, and this is for restoring only the posterior pediatric dentition. So getting the correct fit the first time is not always a straightforward task. Now, simply discarding a contaminated unit would be financially unsustainable. They're about $5 to $10 each, depending upon the company. And with emerging materials such as zirconia becoming more popular, and they're about $50 each, the impact of the emerging and pre-existing materials is warranted. Now, the ideal protocol for sterilizing these devices needs to be universally applied to all the different materials and be cost-effective without damaging their surface or their structural characteristics. Another question in this thesis was an issues of biocompatibility. Now, in the images to the right, we can see a case report, and this is a delayed hypersensitivity reaction to a stainless steel crown. We can see that after the removal of this device, we get resolution of that hypersensitivity reaction. So even though these devices have been in use for over 70 years, we still do have issues of biocompatibility. We've got a few cases here or evidence in the literature. So one paper found trace amounts of metal ions such as iron, nickel, and chromium, which are present in these stainless steel crowns, were 6 times high in cementum compared with controls. We also found fibroblast cell cytotoxicity was induced by metal salt solutions representing those same ions. And another paper found the systemic accumulation of heavy metals such as chromium present in the stainless steel crowns when they were placed in children. So this thesis had 3 main aims or 3 main questions. So the first aim was to conduct a systematic review on the current decontamination practices for these devices to identify common material deficiencies or safety issues we may have. The second aim was a lab-based study to evaluate those disinfection and sterilization protocols on the pediatric devices to establish their suitability for reuse. And the third aim, again, was a lab-based study, and this was a comparative in vitro analysis of human gingival fibroblasts cultured on these devices, and then an assessment of the resistance of these preformed crowns to acidic solutions to better elucidate their suitability for placement. So starting with the first chapter, as I said, this was the systematic review, and this was recently published in the European Archives of Paediatric Dentistry. The rationale behind the systematic review was as follows. There was no published review on contemporary reprocessing protocols, and there's really poor manufacturer guidance around the reprocessing of these devices. However, it is improving. And there's very limited data on the color stability or structural integrity of aesthetic preformed crowns, particularly those zirconia crowns. They only entered the market back in 2010 for the pediatric sphere. So here we can see the preferred reporting items for systematic reviews and meta-analysis guidelines, which we used for this particular review. And the keywords are shown on the screen here. All the selection, screening, review was done by myself and Dr. Zafar, and then Professor Walsh resolved any discrepancies that we had. Here we can see the flow diagram for the Prisma. Initially, we identified 92 papers, and after applying the selection and the inclusion and exclusion criteria that we designed, we ended up with 10 papers for the review. Now, those 10 papers were broadly divided into two groups. Group 1 was changes to material properties such as color stability or structural characteristics, and Group 2 was the efficacy of the reprocessing protocols. For example, how effective is steam sterilization at removing biological contaminants on a preformed stainless steel crown. So the results found that the pre-veneered preformed metal crowns were most susceptible to aesthetic or structural changes from chemical disinfection, steam sterilization, and chemiclave sterilization. In some papers, but not all, the preformed metal crowns developed crazing after multiple autoclave cycles. And a common theme was that the zirconia crowns are least affected by the reprocessing protocols. So some of the limitations of this systematic review were the experimental disparities between the various papers. So obviously the reprocessing parameters do change and vary depending upon who performed them. And of course, the manufacturers used. There's quite a few pediatric companies out there. Secondly, a lack of robust studies. Now, we only identified 10, and that was all that was available, unfortunately. So we may need to include and expand our search criteria for other dental materials that are still used within the pediatric sphere. That can be space maintainers by de novo, orthodontic wires. There's many other options and materials we can investigate. So in conclusion, the systematic review found that the manufacturers need to better define the reprocessing protocols for the supplied material, and consensus needs to be reached on recirculating the contaminated preformed crowns. So what the manufacturers are telling us is not really lining up with what we're doing in current dental practice at the moment. With advances in alternative technologies such as hydrogen peroxide gas plasma, this offers new scope. But what this review really does is it offers a blueprint for future studies by identifying contemporary reprocessing protocols or consistent material deficiencies that we may be finding. The second chapter was a lab-based study, and this was to look at the effects of those decontamination protocols on the aesthetic, morphological, and material composition of preformed pediatric crowns. And this was published in the International Journal of Paediatric Dentistry last year. The rationale for this study was that the systematic review identified the material shortcomings, and there's been limited work into the effects of the decontamination practices on pediatric preformed crowns. So it really was timely for a comparative study to be conducted. The images shown here just show some of the equipment that we use. So the thermal washer, ultrasonic, the steam autoclave, and the chemical opal disinfectant. Here we can see the experimental design for the second chapter. So we have 3 types of preformed crowns with the stainless steel, the veneered stainless steel, and the zirconia crown. Each of these crowns underwent 1, 5, or 10 cycles, and I'll talk about the reprocessing groups in a moment. And it was largely divided into a qualitative and quantitative aspect. So for the quantitative aspect, we had the EDX analysis, which is to characterize the material by composition, and secondly, color analysis to look at changes in RGB color values and luminosity. The qualitative, we can see we had light microscope imaging and SEM to look at changes in the surface topography. And again, I'll discuss these in a bit more detail shortly. Here we can see the decontamination groups that we applied, and in the images to the right, the various crowns that were used. So treatment A was the control, which is untreated. Group B was ultrasonic followed by steam sterilization. Group C was the thermal washer followed by steam sterilization. And Group D was chemical disinfection only using Opal. And as I said, each of these underwent 1, 5, or 10 cycles. Sorry, if I jump back for a moment, so the reason we really did this was to replicate what we might see in everyday dental practice, because these crowns just go through the sterilizer. They're not tracked with barcodes, they're not scanned, they're just thrown back in the cupboard and you go and pick one up with no idea of how many times that particular device has undergone treatment. So here we see the results for the EDX analysis. So this was done to see whether we have any change in the material composition, both before and after sterilization. This particular data set here represents the control for the stainless steel crowns. And if we slowly transition across, we can see the same material undergoing the thermal washer followed by autoclave sterilization after 10 cycles. And there's not really much difference between the composition of that crown before and after. And that was consistent for all of the materials that we tested, irrespective of the number of cycles that it was put under. Next, we can see the light microscope imaging. Now, this was done to really replicate what one might see in dental practice or clinical practice chair side. And I would draw your attention to the middle row, which is the pre-veneered stainless steel crowns. It's a bit difficult to see on the screen, but take my word for it, there is evidence of fragmentation of that resin coating on top of the stainless steel substructure. Compared to the zirconia crowns, which are very stable, and the preformed metal crowns, this was fairly consistent for that pre-veneered stainless steel crown, and it really started to appear from 5 cycles onwards. Now, all of these images here represent the upper ends, that being 10 cycles, and that's for the ultrasonic, the Opal disinfectant, or the instrument washer. We also conducted scanning electron microscopy, and this was done to identify anything we may not be able to see clinically chairside, so evidence of cracking, grazing, fractures. For all of the materials that we tested, irrespective of the magnification or the decontamination group or the cycle number, there was no noticeable differences that we identified. We also conducted color analysis. Obviously, this is very important if you use an aesthetic crown, such as a zirconia crown or a pre-veneered preformed metal crown. Mum and dad are paying more money for nicer results. And if you're giving them a crown that doesn't match the translucency or the shade of the surrounding dentition, they're generally not quite happy. So I would draw your attention again to the pre-veneered preformed metal crown, and we can see statistically significant differences in a number of the blue channels, the green channels, as well as the luminosity. And this again began at 5 cycles onwards for the instrument washer, followed by steam autoclave, or the ultrasonic, followed by steam autoclave. Now, a really key point to take away here is this zirconia crown on the bottom right-hand side of the screen. You can see just how stable those various channels are compared to the stainless steel crown or the veneered stainless steel crown above. The image left there shows the way in which it was done. So everything, of course, identical lighting conditions, and we had a standardized color chip there. So the limitation of the second chapter, it was certainly limited by the exposure to different chemical disinfectants. What we used in the instrument washer, what we used in the ultrasonic bar was according to manufacturer instructions. And we're aware that disinfection and sterilization practices can vary significantly between different regions. So there is potential for the materials to behave quite differently when exposed to alternative parameters. So concluding for the second chapter, we found the degradation of the veneered preformed metal crowns was caused by reprocessing protocols, that being the ultrasonic cleaning or instrument washer cycles, followed by the steam sterilization. The Opal high-level chemical disinfectant was suitable for all 3 types of crown materials tested. The preformed metal crowns and zirconia ceramic crowns were largely unaffected by the common reprocessing protocols. So clinicians should really be prioritizing, materials that are capable of rigorous decontamination protocols for optimal performance and patient safety. And at the moment, the initial data is telling us that the pre-veneered stainless steel crowns may not be fitting that category. So the final chapter, again, it was a lab-based study, was the biocompatibility of human gingival fibroblasts to pediatric restorative materials and the acid resistance of these devices. The rationale for the study was due to the long-term survivability of the preformed crowns. They need to remain until natural exfoliation or until a definitive long-term solution in adulthood is achieved. For example, those hypomineralized molars sometimes need to be covered with a stainless steel crown until late teens or early 20s, until a proper fixed prosthodontic device can be placed. So understanding the behavior of oral tissues to foreign materials and vice versa is vital to improving their design. So we decided to do this because no studies have examined the in vitro biological responses of periodontal cells to preformed crowns. And secondly, whether acidic solutions precipitate the release of any components in these devices. Here we can see the experimental design for this chapter. So phase 1 began with a pilot study, and this was an MTT assay, and this was conducted on human gingival fibroblasts at 24, 48, and 72 hours. After we collected this data, we then moved on to phase 2, which was an aptox glow assay by Paediatric. And this is a much more specific assay. It gives us information in regards to the viability, the cytotoxicity, and the apoptosis, whereas the MTT assay really clumps all of that data together, and we can't see specific cellular processes that are being undertaken. Again, the aptox glow assay was performed on the same cells at 24, 48, and 72 hours. The second portion of this third chapter was really looking at the solubility of various ions in those devices in response to 3 different concentrations of acidic solutions. And I'll discuss shortly why we chose those various chemical agents. So here we can see the results for the MTT pilot assay. So drawing your attention to the graph on the right, we can see the red line indicates the preformed metal crown. These were just little discs that I punched out of a stainless steel sheet that was supplied by 3M. So it's the exact same material that is used to form those preformed metal crowns. And below that, we can see composite resin in green. And that was simply resin that was just gently pushed down with a ball burnisher into the 96 well plate. So this graph is really showing the information in regards to a percentage of control at 100% indicated by the dotted line, and control is just tissue culture plastic. So we can see the metabolic activity significantly declined at 48 and 72 hours for both the preformed metal crown discs and the composite resin compared with the tissue culture plastic. However, there was no statistical variance between those 2 materials. So we can't say based upon the MTT assay that one was better than the other. Moving on to the Paediatric assay and starting with the cellular viability. Again, on the graphs to the right, slightly different. The red line indicates the preformed metal crown. The green line this time indicates zirconia. So these are zirconia fragments. I essentially bashed them up with a bit of a hammer because it's a very difficult material to get into a nice uniform flat disc. Now, for donor 1, which is HGF1, we found that the viability was higher for all time points apart from the zirconia at 48 hours compared with the control. Similar results for donor 2, with both materials statistically outperforming the tissue culture plastic minus the zirconia at 24 hours. It should be noted that for both donors, they were found to be more viable on the preformed metal crown at 48 and 72 hours compared with the zirconia. So interesting result. This is, however, only 2 donors, and whether this holds up with more robust data is yet to be determined. Next, we looked at cytotoxicity in this assay. So both donors reported higher cytotoxicity to the preformed metal crown discs and the zirconia materials compared with the control. Donor 1 cytotoxicity was significant for preformed metal crowns and zirconia across several time points, as indicated by the asterisks. And the human gingival fibroblasts for donor 2, the cytotoxicity was found to be higher for both materials at all time points compared with the tissue culture plastic. In contrast to the viability data, however, neither material was associated with higher cytotoxicity than the other. The final cellular process this Paediatric assay looked at was apoptosis. For donor 1, we can see that the apoptotic signals rose with increasing exposure periods to the discs. However, donor 2 was significantly less responsive with marginal increases in apoptotic events over time. So the second stage or second portion of this third chapter was looking at the acid immersion of these intact crowns. So the preformed crowns were immersed in 0.1% lactic acid, 10% citric acid, and 0.2% phosphoric acid. And that's really chosen to represent various environments that we might find in the oral cavity as shown by the images. Now, the materials used for consistency were the same as the second chapter, so preformed metal crowns, the veneered preformed metal crowns, and the zirconia ones. The samples were analysed for elements of interest after 7 days using ICP OES, and any elemental readings less than 2 parts per million were excluded from analysis. So I would draw your attention firstly to the numerical values in red. These represent the highest parts per million for the particular ion shown within the table. And you can see all of those numerical values are really within one particular material. Again, the veneered preformed metal crown. So a consistent theme throughout the systematic review, the second-based lab study, and the third is starting to emerge with this particular crown. Here we can see a couple of ions of interest. So large quantities of copper, nickel, and zinc were released primarily from those veneered stainless steel crowns, and the 0.2% phosphoric acid was found to be the most destructive, followed by the 10% citric acid, and finally the 0.1% lactic acid. Now, the graphs to the right indicate the copper, nickel, and zinc, and the data is shown just in two different ways. So in the multiple color graph on the left, the x-axis is representing the material. Again, you can see it's clustered or concentrated on that veneered preformed metal crown. And to the right, the x-axis is referring to the particular acid that was used. So as an example, at the upper ends, we found for these particular devices that nearly 600 parts per million of copper were being released, over 100 parts per million of nickel, and for the zinc, over 430 parts per million. Now, a number of studies have been done. So in vitro cytotoxicity to ions released from different prosthetic materials was one paper, and it found that copper, nickel, and zinc to be highly cytotoxic to mouse fibroblasts. Another paper found that copper and nickel metal salt solutions at only 10 parts per million were also toxic to these same cells. So this is far less than what we're seeing released by these particular devices under these in vitro conditions, of course. Now, whether this happens in vivo is a completely different question altogether. So what are some of the limitations or conclusions? Certainly the material fabrication for the zirconia discs. We all know that cells behave quite differently depending on the topography in which they're seated onto. Ideally, not having fragmented zirconia pieces would be nice, just have consistency. It's really here a mixture, I suppose, one could say, of zirconia and tissue culture plastic. But for the purposes of this study, it's not too bad. In the MTT assay, the metabolic activity significantly declined on the preformed metal crowns and the composite resin materials. The Aptox glow assay data was a little bit more over the place, so certainly additional donors and time points need to be tested. We've only gone up to 72 hours here, so what happens beyond that stage is also something of interest. Probably one of the most interesting data points of the whole thesis was the leaching of ions from those veneered preformed metal crowns, and it does raise potential health issues for susceptible individuals. Remember that nickel is generally one of the most common allergies out there. So certainly we could test this in a variety of different cell culture models. So in summary, for the project as a whole, what did we find? So a need for consistent reprocessing guidelines from the manufacturers, as well as industry consensus on the safety of reusing these devices. And since the publication of this report, some manufacturers have now supplied validated sterilization instructions, I suppose, in response to what we published. The veneered preformed metal crowns are liable to color shifts and voids in the resin coating, presumably from excessive recycling. So the study really highlights the need for clinicians to start accurately tracking the number of reprocessing cycles. The MTT assay, we found that the metabolic activity of the gingival fibroblasts significantly declined on the preformed metal crowns and the composite resin materials. And again, the leaching of the ions from those veneered stainless steel crowns does raise health issues for at-risk individuals. So some future directions for this project, really less widely used forms of sterilization, such as hydrogen peroxide gas plasma, do warrant further investigation because they're conducted at a lower temperature than steam autoclave. Search criteria to include comparable materials, as we talked about, so spaces, orthodontic compliances for more robust data. To explore the decontamination parameters in more detail. So we don't know whether it's the steam autoclave or the chemical disinfection or the combination that's causing the material degradation of those resins. So really pinpointing the specific causes. The release of any specific cytokines, such as interleukin-6 or basic fibroblast growth factor. How do these cells respond? What do they secrete when they're seeded and grown on these particular materials? And certainly the biological responses of the periodontal cells to comparable molar concentrations of the various ions that we identified in the final chapter. And of course, thanks to Dr. Sobia Zafar and Laurie, who is in here today, but they were great help throughout my project over the past couple of years. And thanks all for attending. Any questions? Oh, good. Excellent. All right, I'll pass over to Yvonne.
Imagine if out of nowhere, your beautiful baby girl is unable to do the things that she's been slowly learning to do. She can no longer throw. She can't grab. She stops talking. One day, she doesn't just stop developing. She starts to lose skills. She effectively becomes trapped in her own body. For parents of children with Rett syndrome, this frightening scenario is a reality. That description from a news article allows us to understand Rett syndrome, a rare neurodevelopmental disorder almost exclusively affecting females and associated with severe disability. First reported by Dr. Andreas Rett in 1966. It wasn't until Hagberg published a series of case reports in the English literature in the 80s that this disorder became more well known. The cumulative incidence for this disease is 1 in 9,000 or 1 in 10,000 live female births. And we can compare this with other more well-known disabilities such as cerebral palsy, Down syndrome, and autism. And while the disorder was originally thought to be characterised clinically by the existence of 4 discrete stages, the diagnostic criteria for the syndrome has evolved over time and been informed by the discovery of the genetic etiology in the late 90s. The main gene implicated is the methyl CP binding protein 2, or MECP2, which is located on the X chromosome, and it's inherited in an X-linked dominant manner, although about 99% of cases actually arise out of de novo mutations, and so it occurs very, very rarely in males. So after a period of apparent normalcy, the condition is characterised by postnatal psychomotor regression and the development of multiple comorbidities, which include but are not just limited to epilepsy, think growth and nutritional problems, think scoliosis, think respiratory problems such as breath holding, sleep disorders, gastrointestinal problems such as reflux, and susceptibility to bone fracture. And these are only some of the problems they have. The current diagnostic criteria are shown with 4 main and 11 supportive criteria. The occurrence of a set of common and recurring MECP2 mutations in Rett has made it possible to study genotype-phenotype relationships, which have verified the genotype influences on both the severity and the mortality. And although life expectancy has improved in recent decades, mortality rates are still very high. So where are the gaps? Well, although bruxism is a supportive diagnostic criteria for Rett, and while it's mentioned as prevalence figures mainly in case reports, oral health risk in Rett syndrome is largely unknown, with the first small comparative study on this published in 2014. And so this is how and why I, as a paediatric dentist, came to be involved in working with Rett syndrome to improve their oral health, both from an oral health education and also a research perspective, with my early publications also being in the field of oral health and Rett syndrome. And so over the last 7 years or so that I've been involved with Telethon Kids Institute, I've also had a lot to do with the InterRett and the Aussie Rett databases established through the Institute, which have formed the data source for my previous and current research. And importantly, the Aussie Rett database was established in 1993, but it wasn't until over 20 years later that the oral health of these people was investigated in detail, and that I published in 2018. A review of existing literature found that diurnal bruxism was the most frequently reported oral presentation, with the management of bruxism ranging from things like conservative monitoring through to acrylic splints and bite planes, stainless steel crowns, and even more alternative things like acupuncture. Our own Australian population-based retrospective study found that dental extractions were more likely to have occurred in patients living in households with lower household income. And this was in a similar pattern to that seen in the normal population. The study also found that those with a severe genotype associated with large deletion of MECP2 were more likely to have multiple dental extractions compared with those with a milder genotype. And so following on from this PhD has comprised a number of arms, a systematic review to evaluate the efficacy of oral health promotion measures in those with intellectual and developmental disability in children and adolescents, an international observational study, and an Australian prospective clinical, interview, and dental record study, which I'll run through in a bit more detail, and where I've aimed to determine the oral manifestations, risk factors for tooth decay and other oral diseases and their wider ranging impacts, such as barriers to accessing timely dental care. So looking at the systematic review, this was the research question, the PICO question. So how effective are different oral health education and oral health promotion interventions for children and adolescents under 18 years of age with special needs and disabilities in ensuring optimal gingival health, caries experience, and oral health related quality of life, as compared with no interventions or alternative interventions? I'll outline a brief summary of findings here. So the selection process for the studies and paper inclusion pathways is illustrated in this Prisma flow diagram, where 864 articles were found that matched the search criteria. 53 papers were assessed for eligibility, from which 18 were used for qualitative analysis and a further 11 for meta-analysis. Most of the articles had a very high risk of bias, and the effects of interventions are summarised according to comparison type. 8 comparisons were identified, and 3 of these comparisons involved more than one study. And the main findings were as follows. So from the interventions that were being used, there is low certainty evidence that fluoride interventions provided a long-term reduction in caries with those with IDD. And for chlorhexidine, some evidence, although albeit with very low certainty, for short-term and long-term reductions in plaque and gingivitis. There was evidence of moderate certainty for short-term reductions in dental plaque from the use of modified toothbrushes, but not compelling evidence for powered toothbrushes. And overall, many of the studies examined only provided a low quality of evidence. And so future trials need to use more rigorous methods, larger sample sizes, and clearly define their participants and outcomes to increase the precision and reduce the bias. And additionally, having using validated outcome measures would standardize the comparisons used for longer term follow-up. And it would also be useful for studies to report all the group means and standard deviations, as well as their change scores to facilitate meta-analysis. So moving to the international study. Paper 1 from the INTERACT study explored the oral health service utilisation of those with Rett syndrome. And so using data in the INTERACT database provided by English-speaking families of individuals with a confirmed MECP2 mutation, the study investigated relationships between dental problems, oral care, child factors including bruxism and use of gastrostomy, and socioeconomic indicators. And the study also explored relationships between dental presentations and socioeconomic child and family related factors. There were 232 families invited to the study, and 216 families completed it with a response rate of 93%. Individuals with Rett syndrome experiencing bruxism were more likely to access dental treatment, and those who had full oral feeding had a higher incidence rate of dental treatment than those with full tube feeding. And a conservative underestimation of the overall dental caries progression rate revealed that this may be similar to that of the normal population. We found that a higher maternal education level may confer a protective effect for oral health outcomes in Rett syndrome, and nevertheless, families generally tended to value the importance of oral health despite reported difficulties in day-to-day mouth care. Paper 2 from the INTERACT study further explored the parafunctional habits of those with Rett syndrome. And so retrospective observational data of those with MECP2 mutations in the database was used to investigate experience of parafunctional habits and bruxism and their relationships with genotype and snoring using multivariable linear regression. The prevalence of any parafunctional habit was 98%. Bruxism was reported in 2/3 of them, and the common patterns were both diurnal and nocturnal bruxism at 44%, and exclusively diurnal bruxism at 43%. Now, in Rett syndrome, there is an association between clinical severity and the genotype, and our findings for bruxism were consistent with this. Rett syndrome patients with milder mutations were less likely to have bruxism, and patients with a more moderate P-arginine 106 tryptophan mutation were less likely, or the more severe P-arginine 1868 mutation were more likely to have frequent bruxism, respectively, than those with a milder C-terminal deletion, which is not shown on this slide. The P-arginine 168 mutation was linked most strongly to bruxism as well as to sleep disorders. And in terms of associations of bruxism with snoring, the relative odds of having occasional or frequent bruxism in the day or night time were increased 3-fold in Rett syndrome patients who snored. Similarly, the relative odds of constant bruxism at night were increased by over 6-fold in those who snored. And these results support the notion of a link between frequent snoring and frequent nocturnal bruxism, and with frequent bruxism regardless of the time of day. And such findings are consistent with the general adult population, where both loud snoring and obstructive sleep apnea have separately been associated with an increased likelihood of nocturnal bruxism. And moving to paper 3 of the international study, which recently received a bit of press around the time of the Rett Syndrome Congress in Nashville in the US. Paper 3 looked at the caregiver and external beliefs regarding professional dental care access for those with Rett syndrome, and also the relationships between caregivers' perceived value of oral health and the dental anxiety of caregivers and their daughters with Rett syndrome, and their relationship with dental treatments received in the professional setting. The majority of families favourably rated the standard of dental care received and ease of attending dental visits, with a smaller proportion reporting varying degrees of difficulty. And the majority of families reported that their daughter had low or moderate or very low levels of dental anxiety, and there were similar ratings for the caregivers' own levels of dental anxiety. Now, this table summarises reported barriers to dental care in this group. The main reported barriers to dental care access for those with Rett syndrome were primarily dentist-related in nature, regardless of the dental service history, and echoing some themes in the wider literature for intellectual disability. Comparatively fewer reported cost as a major barrier, in contrast to that reported in the wider literature for intellectual disability and the wider general population, which could be explained by socio-demographic factors, as 60% of this international sample had a university education. And it's been previously suggested that this group may be more advantaged compared with the population-based Australian cohort. And it's acknowledged that issues stemming from the cost of dental services will invariably be linked to the model of care and coverage by health insurance, and this may vary between the different jurisdictions and countries. Increasing levels of caregiver-reported dental fear were associated with less frequent dental checkups or for any appointments for affected individuals. And similarly, for those with low or moderate dental fear compared with the reference group, dental examinations and overall dental appointments were less frequent when the patients with Rett syndrome themselves had perceived increased levels of dental anxiety. So moving on to the Aussie Rett Dental Records Study. So the objectives for this particular study are to assess the various factors relating to the family's, the girl's dental service history, with the variables taken both from the records and charting and also from the child and family covariates on the Australian Rett Syndrome database. And the substantive historical data on their oral health status and the management of this cohort will complement additional data collected both clinically and parent proxy in other arms of this overall project. So to date, we have received 102 out of 105 active consents returned, with public dental records from across at least 35 different health districts across Australia, with private records from at least 50 different private health jurisdictions. Moving on to the clinical study. So the objectives of the clinical study are to identify the oral manifestations of Rett syndrome by comparing those with Rett syndrome in Australia with sibling controls, and to assess risk factors for dental caries and other oral diseases, which has included samples of dental plaque and saliva in those with Rett syndrome and their sibling controls, and to determine the oral healthcare needs and barriers and enablers to obtaining oral healthcare for individuals with Rett syndrome in Australia. And now, because of the dispersed location of these families and of the tertiary referral treatment centres for people with Rett syndrome, this study has had to be by design multi-site in nature. And so I have been conducting home visits in my home state of South Australia, last month in Western Australia, once the borders had opened, and after a few months after that, and also now flying here to Queensland. And this has been the preferred method for examination and has been well received by families in previous Aussie Rett studies. The dental examination for cases and controls has consisted of examination of the oral tissues and dentofacial characteristics, the resting salivary pH, and also dental plaque biofilm and its metabolic activity. A short dental questionnaire has also complemented the clinical examination, which has been adapted from the dental module of the Interret database. Now, to date, the clinical study retention rates are as shown, with about 1/3 dropping out from the WA and the Queensland samples due to the experience of COVID in the families. And currently for the Queensland home visits, we have started a second round of recruitment to address the study attrition. It's important to note here that the data collection for the South Aussie sample occurred during a period of zero community transmission, with recruitment beginning straight after the Powerfield cluster subsided in December 2020. And in contrast, for WA and Queensland, the home visits have occurred after the borders have opened, and where there's been community transmission, and where home visits, the home visits protocol that we've had to follow has since changed to include a COVID-19 home visit checklist, and also additional risk mitigation measures. Moving on to the qualitative study. So I have conducted interviews of parents with a child with Rett syndrome in Australia, and the aim has been to explore barriers and enablers to accessing dental care, as well as to identify factors that affect the oral health related quality of life in people in Australia with Rett syndrome. I've completed 31 interviews from 31 families spanning different states across Australia, with an even representation of rurality, age and genotype. And the interviews have spanned anywhere from half an hour to over 2 hours duration. Analysis is in progress, but in terms of preliminary findings, one key theme that emerged from the interviews that I want to highlight to you was the experience of pain in relation to describing and defining what these families consider to be a good and bad oral health related quality of life with regard to their daughters. Numerous families did suspect a dental related cause when their daughter showed signs of distress, of pain, with no other evident indication. And for families where the daughter used a high-tech communication, such as an eye gaze device, a number of participants described how limited how limited these devices were when their daughter was in extreme distress and, for example, dental pain. And other parents also described the challenges of communication to eliminate potential causes of pain when their daughters were distressed. Many families also described their daughters as having an extremely high pain threshold, a concept that is consistent with previous research on the altered pain sensitivity on those with Rett syndrome. And while individual expressions of pain varied, this was a key theme that was highlighted by many families, as was the absence of pain when describing how they would define a good oral health related quality of life, as well as the ability to enjoy activities of daily living, to enjoy the sun, run, to jump, and not be affected by pain. So stepping back, why does this matter? Why is this important? Well, in summing up, to explain where I'm going with this, I'd like to use and borrow the Save the Children's positive parenting framework as an analogy, which I think not only best encapsulates what I love about paediatric dentistry, but what where I actually think encapsulates our approach here to those with rarer disorders. Firstly, we need to identify the long and short-term goals. We want to understand the condition, the problem and its parameters by working closely with families, our key stakeholders, by putting ourselves in their shoes and building a logical approach to understanding the context and enabling and predisposing factors. Then we can problem solve and start to identify accurate ways to measure that progress. Coming back to Rett syndrome, if we can identify problems better, then we can look at early interception. Research tells us that caregivers and clinicians underestimate the dental treatment needs of those with disabilities. And this is especially important for Rett syndrome, as these people cannot communicate and have decreased pain sensitivity. Therefore, this body of work is meaningful not only to clinicians, but also families who will travel many different highways to seek care for their daughters. This research will allow us to tailor targeted oral health promotion strategies for this underrepresented group and provide blueprints to approach other underrepresented disability subgroups in future.